doing this because Uthman was discussing with us a similar case. So this case, actually, she was a 68-year-old female. Her comorbidity was hypertensive diabetic dyslipidemia ischemic heart disease. She had a history of acute inferior wall EMI in 2016, status post-retroplace at that time. She had cardiogenic shock with acute kidney injury and liver failure. However, she was in CCU, emergency cath. They did for her RCA and distal circ disease, moderate to severe disease, and mid-LAD. They just did a calbrate at that time, which is planned only RCA. Then they did MPI for LAD in 2 to 3 months, and she was discharged at that point. And MPA showed that she had LAD territory ischemia.
هيثم ايش الام بي اي؟
الاسكيميا study.
ايش؟
myocardial perfusion حاجة والله ما I don't know
Okay.
they stand for what.
Okay.
طبعا just to اللي هي myocardial perfusion they did it for her. You can see the uptake later on is better. To be honest with you, here I think I'm not sure how to read this. Even when I presented one of the consultant cardiologists, I'm not expert يعني on this one. However, there was a reversible ischemia on the LAD territory, so she was admitted.
It's viable, بس inferior wall it's not viable.
الصف الأول هذا الستريس
هذا الأول الستريس.
هذا أول واحدة اطلع أول اثنين.
أيوة.
هذا اللي فوق هذا الستريس. هذا الريفرسبل اسكيميا وتحت عندك الريست.
هذا الريست.
اي فهذا هي تشوف هنا في الديفكت الموجوده ولما عملوا لها ستريس وديبيتامين كيف صار فيه ريفرسبل يعني صار فيه ابتيك احسن فهذا يعتبر انه اللي هو انماتشد او نوت فيكسد ديفكت فيعتبر ريفرسبل. عاد هم
اللي فوق المفروض اللي فوق البرفيوجن واللي تحت الميتابوليزم صح؟
لا هذا مو بيت عثمان ترى عشان واخذ روتيشن في الايميجينج فهي هيز نوز بيتر.
لا هذا كلام دكتور حالي امس.
هذاك بيت هذا ما اعتقد بيت هذا طوله هنا ادينوسين شوف.
اوكي.
صح ولا لا عثمان؟ This is different.
هم نفس الشيء حتى في الثانية حتى في البيت سكانينج بس يختلف المادة اللي يستخدمونها والبيت يكون more accurate than اللي هو اللي يسمونها الفايبلتي تيستينج البرفيوجن ستادي.
بس البيت في برفيوجن وميتابوليزم ما في ستريس صح؟ يعني اللي فوق هنا ما في برفيوجن وما في ميتابوليزم فإتس نوت ريفيرسبل اسكيميا. إذا كان ما في برفيوجن بس في ميتابوليزم that's mean reversible ischemia.
To be honest with you, I'm not expert on this one. I cannot.
ميتابوليزم يا برفيوجن ميتابوليزم وش تقصد فيهم؟
اللي هو there is two tests تسويهم في البيت. البرفيوجن يعطيك اللي هو البلد سبلاي. الميتابوليزم يكون على الليفل اوف ذا سيلز فيعطيك اذا السيلز فايبل ولا لا. فلو كان في ما في برفيوجن that's mean there is ischemia. if ما اسمعك عثمان.
هي يختلفون واحده للاسكيم واحده للفيابيلتي واحده للبرفيوجن. اذا ما كان في برفيوجن معناها انه اسكيميك والفيابيلتي يشوفون فيها الابتيك او الميتابوليزم اللي هو يحقنونه بالاف دي جي اللي هي فلورو ديوكسي جلوكوز
بالضبط. فاذا كان في مس ماتش هذا يكون اسكيميا. اذا كان
الميتابوليزم اذا كان في ابتيك اذا الميتابوليزم اذا التشو تاخذ التشو اذا التشو صار فيها ابتيك للماده هذه اللي هي الاف دي جي هذا معناها ان it is viable tissue.
viable tissue صحيح.
طيب واذا ولازم تكون تاخذه within time limit. لما يكون في delayed enhancement انا تاخذ الاف دي جي في delayed بعد يعني بعد دقيقه مثلا، هذا سكار تيشو ما هو فايبل تيشو.
اوكي.
طيب بالنسبه للبرفيوجن هي تقريبا نفس الفكره او نفس الترتيب حقهم. انت تشوف تقريبا نفس الصوره اللي تطلع لك.
اي عشان كذا انا قاعد اقول لك يعني عشان تفرق بين السكار والاسكيميا. السكار ما راح يكون فيها برفيوجن ولا ميتابوليزم. الاسكيميا هيكون في لو برفيوجن بس still there is metabolism. فلما يكون في مس ماتش هذه اسكيميا or hibernating. لما يكون في ما في مس ماتش but both of them low that's scar tissue.
ايوه بالضبط. هم الكلمات اللي مو حلوه اللي هي ماتشد برفيوجن او يقول لك فيكس ديفكت، هذه كلها باد ساين. عندما يكون ان
عثمان
هلا.
طبعا هي incomplete sentence. match perfusion هذا normal. matched low
ايش؟
هذا scar. matched perfusion هذا normal. matched reduced هذا scar.
هو نتكلم عن ماتش ديفكت ما هو ماتش. احنا ما نتكلم عن نورمال برفيوجن، نتكلم عن ديفكت. اذا كان في ماتش ديفكت هذا معناها
اوكي
سكار تيشو.
هيثم
هلا دقيقة بس. ادوني بس ثانية واحدة بدخل ولدي على البيت، دقيقة بس.
اتوقع الدكتور كان هيعطينا مور سيناريو في المايترال. انتوا كلكم رحتوا ولا بس هيثم؟
لا موجودين.
طيب sorry for inconvenience. طيب بس so our hospital course, our patient was admitted on 1st of September 2019 as a case of unstable angina. For 2 months, elective cath was planned for her with normal ECG and cardiac enzyme. Examination, all her examination was actually within normal. All her lab was normal, creatinine, albumin, hemoglobin was 15. Her chest X-ray also within, it was normal and remarkable. Her echo also, she had normal left ventricle and systolic function. However, no significant valve lesion. Here you can see long axis parasternal view with good RV, good LV function, no significant valve lesion. Here you can also appreciate there is some hypokinesia on the inferior wall. That's it. No TR, no MR, significant in both. So actually, she was planned for elective diagnostic cath plus or minus PCI at that time. She was admitted under cardiology. She found to have a proximal LAD, which involved diagonal and proximal circ and patent RCS10. Decision on the cath lab was made to go for PCI of both lesion, LAD, and circ. Her calculated syntax score was 15. PCI to the LAD was done successfully. However, PCI to complex circ complicated by guide wire fracture in the circumflex and left main perforation. Unsuccessful attempt by interventional cardiologist for retrieval. Here you can see the patent stent on the RCA. Next one, the same, just to show you more. And this one, yeah, this is the lift system, just to see the LAD lesion and the circumflex lesion as well. More LAD. So a successful LAD stenting was done with any uneventful things. What you can notice here, guys. So you can see in this view, this is an RCA stent. Notice this one. What is this? You are engaging here in the left main, and you have wire. See, here the ostium of the left main. See the wire. What is it?
طالع برا
Yes, it was actually here showing evidence perforating the going from the posterior wall of the aorta. Furthermore, this is just to show you the complexity before that picture of multiple wires and the complexity of circumflex. Here, furthermore, you can notice this is a left main, and here the wire is going clearly perforated. So notice the dissection in high OM and circ and wire embedded in the left main. Most likely at that time could be perforation. Patient become, initially she was actually stable totally. Cardiac surgery consultation was initiated. I saw her actually in the cath lab, seen by the consultant on call. Then we emergency life-saving cardiac surgery, removal of fracture wire and cabbage was explained to the patient and family, and high risk also was obtained. Calculated Euro score is 18.4 and STS score is 22.6. Then patient, as I told you, she was not on inotropic support, very mild shortness of breath when she was in the cath lab. She was shifted from cath lab to the operation room. When she started to be shifted, she was on minimal actually inotropic support. Then upon induction, she started to be hypotensive, pericardia, escalation of inotropes, and bolus is AB plus phenylephrine. Then cardiac arrest and CPR was initiated. This is even before we are doing, not yet drip. We didn't, all of us just doing timeout and all that. So we just scrub, dripping was done fast on the chest of the patient. I was doing CPR, then the consultant came. We both wear our gown. He emergently opened the stenotomy, pericardectomy. After he did the pericardectomy, tamponade, gush of blood came, and after that, the heart started to beat. Then we went aortic and RA cannulation. We start cardiopulmonary bypass, cooling. Then we apply our aortic cross clamp, antegrade cardioplegia. We give it. Heart was arrested. Aortotomy made, dissected. We can appreciate at that time dissected left main, cut through and spiral dissection that involved the circumflex. And it was imagine, and when we opened the aorta, it was going back posterior of the aorta. Okay, you know the course of the circumflex. So at that time, actually, aorta completely transected. I mean, not only the aortotomy that usually we do for the AVR, we completely transect the aorta for better view and approaching the left main. And we remove the wire from the left main. It was there, and we ligate the left main from inside and outside. Then distal anastomosis was performed, SVG to LAD, SVG to OM, / could be left PDA, it was big. Then we noticed that left main was dissected up to its root and almost completely transected. The repair was difficult at that time. distal LAD, this is why we ligated. Distal LAD anastomosis done, good flow. Cardioplegia was given through the LAD, through the OM, with a good flow when we give it. Then
ما كان في شيء هيثم ال AD ها؟
What you no.
ما كان في dissection.
When we get no, we don't know the extent of the dissection from the origin. Okay. So left main ligated and aortic root repair from outside because the capital procedure cannot be done because there was no lumen. يعني the left main was totally dissected. If you يعني عارف, it was really dissected. There is no place to take it as a bottom or to create a capital procedure. Then
لا
we
أقصد
closed
لما
our
فتحتوا
totomy.
ال AD عشان تسوون الانستموسز ما كان في dissection في ال AD.
No, we did it mid LAD and no dissection. Even when we did the CERC, no dissection reaching that point. And what we saw, that dissection is up. So then our totomy closed, then graft anastomose proximally on ascending, rewarming, cross clamp off after hot shot was given. And we were giving intermittent cardioplegia and also through the graft in the case. Weaning was difficult in the cardiopulmonary bypass, from cardiopulmonary bypass. And flow, after that, we measured the flow on the OM and LAD. The BI was 1.8 and 3 respectively. On LAD was 1.8 and on the OM was 3 BI. However, cardiopulmonary bypass weaned off at that time, but she was on very high inotropic support, IBI, nor-IBI, vasopressin, with certain intra-aortic balloon pump as well. See, this is her heart off pump. You can see it's barely moving all the segment of the heart. This is, by the way, transgastric view. Which, yeah, this is transgastric view. You can see it's barely moving at the level of the mitral valve annulus. Here, which one? Mid-esophageal view, parasternal, what they call it, parasternal long axis view. You can see it's barely moving and hypokinesia, severely hypokinesia of all segments of the heart. Just see this one. It's really, and this is in very high inotropic support, plus spacing, plus intra-aortic balloon pump. Just further to show you more picture. So patient blood pressure was, I recall, 60, 50s, borderline. Most likely she had got a hit from the left main dissection. She was on high pharmacological and mechanical support, intra-aortic balloon pump. At the team decision at that time, we discussed with the cardiac anesthesia, cardiologist, cardiac surgeon. We discussed with other cardiac surgeon other than the one who was operating. And because of her age, all comorbidity and the scenario, she was not candidate for ECMO. And because she was continuing to deteriorate and she was starting to develop VTAC at the end, declared dead at that time, 1905. So patient was closed, family informed. Then patient was shifted to the ICU. The cause of death, post-CABG and repair of post-PCI, dissection of left main, and cardiogenic shock. So regarding, you all familiar with the guidelines. Patient, I just want to highlight one thing, that the patient with revisit disease, if it is syntax score 0 to 22, it is class 1 to do CABG. However, you can do PCI, but it's class 2B, okay? 3-visit disease, syntax score more than 22, it's class 3 to do PCI, okay?
بس ال STS score حقها كان عالي صح؟
Yeah, very high because of the emergency surgery.
عشان emergency مو عشان هي أنا حسبت okay. I thought
we took her as
high surgical
emergency.
risk عشان كذا PCI was done.
No, it was syntax score was 0 to 22. Nobody consult us before doing the PCI for the LAD plus the CERC, and she's diabetic, and this is even why I brought the guideline. Then I get your points. When you favor PCI, if you have and favoring CABG. And favoring CABG patient with diabetes, reduced ejection fraction, contraindication to dual antiplatelet, recurrent diffuse and stent stenosis, or you have syntax score 23, anatomy likely resulting in complete revascularization with PCI, or severely calcified coronary artery, limiting lesion expansion, or you need to do another cardiac procedure. I mean, AVR, MVR, name it. When you favor PCI, if you have severe comorbidity, advanced age, frailty, reduced life expectancy, restricted mobility, and conditions that affect the rehab process, or syntax score low with multivessel anatomy likely result in incomplete revascularization with CABG due to poor quality or missing conduit and diffuse disease. She will not benefit with complete revascularization. If she has severe chest deformation or scoliosis or radiation before, or porcelain aorta, of course. Same emergency CABG, طبعا it is a class 1 to take the patient after failed PCI with ongoing ischemia, but I believe it is class 2A here. It is class 2A, level of evidence B. Emergency CABG is reasonable after failed PCI for retrieval of foreign body, most likely a fracture, guide wire, or stent in crucial anatomic location. This is the same, but this is class 2A in our case, I mean. So
I think in your case, Haitham, there is dissection, so it's complicated PCI. It's not the main. It's not to retrieve the foreign body. It's to fix the dissection and do revascularization.
Yeah. However, in American guideline, I cannot find. In the European, the latest one, I cannot find this one. And I didn't find it with the class. They said you need to take the patient emergency, but without mentioning of the class. But in the AH American guideline, they mention class 2A. Okay.
لا أنا فاهمة قصده حسين إنه عشان المايكارديوم is jeopardized, so it's a class 1 indication. ما هو just for the retrieval. صح قصدك كذا إحسان ولا أنا فاهمة غلط؟
صح.
Okay. I think you're right.
يعني لو ما كان في dissection وما في ongoing ischemia, وthey يعني just for taking the wires, it's class 2A. But the main idea of your surgery is to save the patient life and fix the ischemia. It's not to take the wire out, right?
Yeah. But this is what it mentioned in the guideline. You get my point. And they mention it clearly, fitting our case, failed PCI for retrieval of foreign body. Most likely fracture guide wire or stent.
وليش مو emergency CABG to recommended after failed PCI in presence of ongoing ischemia and threatened occlusion.
Yes. You are right. خلاص, get it. You are right. It's class 1B. You are right. Right. So I just have a quick review about the topics and so changing trend in emergency coronary artery bypass. Actually, the percentage it was decreased over the year from 2.7 to 1.7 over time, and despite changing preoperative risk profile, the operative mortality of emergency coronary bypass has remained stable, no changing, and it is high morbidity. And actually, in other study, found that impact of delays to cardiac surgery after failed angioplasty or stenting is not advisable, because it will increase the risk and causing harm if you delay your emergency surgery. So you need, despite the high risk, as Dr. Farid, it is high risk, but you need to take the patient because there is no other option for this patient. And the emergency coronary or CABG in contemporary percutaneous coronary intervention era, you can find that the need for emergency CABG, it was only in 0.61 as cases among their cohort of 18,000 patients, and the major indication were extensive dissection, perforation or tamponade, or recurrent acute closure of the stent, and the prevalence of emergency CABG decreased from 1.5 of PCI in 92 to 0.14 in 2020, and in that paper was published in Circulation, showing that because of the advancement of the PCI and the skills of the interventional cardiologists, these percentage start to be less and less. طبعا الoperator experience from the same paper and need for emergency CABG, actually it will not be affected if it is happen. It can happen to experienced interventional cardiologists, or it can happen to junior interventional cardiologists. Here, just to show you the trend over the years and improving or decreasing over the years. Need for emergency CABG after failed PCI, usually the risk factor for that, the prayer, if they have prayer CABG, increase left ventricular ejection fraction, if they are in acute MI, female 6, or they are on platelet glycoprotein 2B2A inhibitors. Also, multivariable logistic regression modules showing that also female 6 stent use number and year of the procedure that being performed. I mean the stent use either in 95 or 20, because as you see in the previous graph, it's trending down over the years. Complications of coronary intervention, abrupt closure or dissection or perforation. This was nice review article showing that causes and treatment of abrupt closure. The cause either dissection, no reflow, thrombus, or acute stent thrombosis, and for each one you have an interventional way to deal with it, all that being defined and showing good successful. But at the end of all these, the stent of the vessels, you do stent IVUS, or you consider giving GB2B3A inhibitors, or you do thrombectomy if there is thrombus, or put stent on that. Or for example, if you have acute stent thrombosis, you do redilatation or confirm effective anticoagulation. If all that failed, you need to go for emergency CABG. Here, just to the classification of coronary artery dissection. If you remember yesterday, Dr. Salih Shlash was talking about this. So you have type A, B, C, D, E, F, but it's depend on, just imagine type A is minor and type F dissection leading to total occlusion. In our case, actually, it was like spiral luminal filling defects and through. The risk factor, if you do oversizing balloon, higher pressure balloon, stenting of tapering vessels, stent of lesion recrossed after dissection. If you stent total occlusion with sub-intimal navigation of the wire, this is, if you remember also the interventional radiology, if you have total chronic CTO lesion, they don't like to take it because the risk of dissection is high because of the burden of calcification. Same classification of coronary perfusion, prevention of coronary perfusion. This is just an algorithm. I found it in one of the recent review that if you have a coronary perfusion, immediate prolonged balloon inflation, and all this was done actually in our cath lab, immediate inflation of the balloon, discontinuation, reversal of anticoagulation, treatment of vagal reaction or hemodynamic compromise, you repeat the angiogram. If you have sealed perforation, it's easy, just observe and serial echo. Echo to observe if there is a perforation that lead to cardiac tamponade. This is why they mention echo, and you need to keep it in your mind. Persistent extravasation, you repeat balloon occlusion more than 15. If the vessels more than 2.5, stent graft, unsuccessful urgent surgery, versus is small, you just do micro coil or gel foam or embolization even of that vessels. If all that unsuccessful, that patient need to go after that to urgent cardiac surgery. This is the same, the impact of catheter-induced iatrogenic coronary artery dissection, or with or without post-procedural flow impairment. Just to show you that over the years, the trend of this complication is trending down. However, still is there. Same actually what I discussed before, but just from recent review article. The surgical consideration, I think we touch on it. Anesthesia, bleeding, choice anesthesia. You need to do rapid narcotic-based regimen with perfusion and surgical team to be prepared to respond to catastrophic with a TEE as what happened with us. Bleeding, those kind of patients, they will have a higher risk of bleeding because of loading dose of all kinds of drugs that they took in the cath lab. The choice of conduit, as a routine, you do the same, you do lima, but if the patient is unstable, you just go to vein and that's it. This is summary of management strategy. If you have a coagulopathic patient, we discussed this yesterday.
This is emergency, so all vein graft will be reasonable.
Yeah, of course. With this unstable vein graft, and that's it. But I just mentioned what's been in the literature. Intraoperative, use cardioplegia, antegrade, retrograde, as we said, to achieve and through the graft as well, to achieve satisfactory diastolic arrest with good myocardium protection, and also throughout the grafts. Put the LV vent to decrease metabolic energy and O2 consumption by 60% and help protecting the myocardium. Cooling the patient, as cooling will decrease consumption by 10%. Early initiation of pump, peripherally or centrally. Use a Packberg protocol, including warm induction. Then, as I discussed it with Dr. Rakan, however, it is debatable, but this is what's been mentioned in the literature, and it is also just a series. It's not a controlled trial to say this is the way to go. It is important to do controlled reperfusion, very important, and this controls the rate of reperfusion, minimize cellular damage and myocyte damage, because controlling reperfusion will decrease the myocardial infarct size and ventricular injury. Ischemia also can lead to anaerobic metabolism, which lead to decrease adenosine triphosphate production and increase intracellular calcium to decrease amino acid precursors such as aspartate and glutamate. As oxygen is reintroduced into region, oxygen-free radicals start to generate and can lead to cellular damage, cellular swelling, and or counteractor leads to no reflow phenomena. And this is what I was explaining yesterday, that limit the recovery of some myocytes and possibly adds to irreversible injury to others. Free radicals during ischemia and the time of reperfusion can lead, and calcium overload lead to explain the cellular injury. And this is, I think, what happened to our patient. This is just the type of reperfusion injury, either lethal, which is cell death secondary to reperfusion, or vascular one, reperfusion arrhythmia, or stunned myocardium. Vascular, if you have progressive damage, causes an expanding zone of no reflow and the deterioration of coronary flow reserve during a phase of reperfusion, or you have reperfusion arrhythmia, which is less severe form. That arrhythmia, mainly ventricular, that occur shortly after reperfusion, but the patient will come back. Stunned myocardium, which is post-ischemic ventricular dysfunction, it will take weeks to recover. Support, you just need to use pharmacological and mechanical support as needed, and the patient need. But of course, use of mechanical support indicate high morbidity and mortality in the literature, reaching 80% in those emergency CABG. If you have any question, or if you want to discuss something more, please feel free.
هيثم، لما يكون في complete dissection يعني all through the fizzles, do we have, as a surgeon, do we have something to do?
Complete dissection. You just do
dissection. Let's
coronary
assume نفس
artery
الحالة اللي عرضها الدكتور شلاش. Dissection في RCA involving all the vessels till the end of the BDA.
No.
Can we do
خلاص,
something
you cannot
about
do
that?
it.
في salvaging procedures, but I'm not sure about the evidence. You can anastomose it directly into the muscle, which has been done, or you can also anastomose the vein. So I'm sure they're not as good as anastomosing the arterial grafts, but they're considered salvaging procedures. Maybe someone can check the evidence and let us know.
Anastomose what? Anastomose what, Professor?
The myocardium itself. Anastomose the myocardium.
I don't know.
Yeah.
I don't know, but what I know, I'm not expert. If it is all dissected, so there is nothing to graft on. I will just, if I need to go in because of the bleeding or perforation, like free wall rupture that happened, you will just secure that area and that's it.
I mean, if there's a way to repair it, if the kind of size is reasonable, you can repair it. Fair enough. But if you can't, it's a bad situation to begin with. I think what I mentioned are only like salvaging procedures. I'm not sure about the results though, or if they're being done anymore.
And if it is come to me, I will call any other consultant to senior one to do it. I cannot do it, or he will be with me.